Now let's look at some wide complex tachycardias. And this usually is broken down into one of 5 different types. You can have V-Tach or Vfib, SVT with Aberrancy, and I'm going to explain that term in just a second. A Pre Excited Tachycardia, and I'll explain this term in just a second too. A ventricular paced rhythm, and a polymorphic tachycardia, wide complex, or torsade de pointe, or de pointe, I don't know how you say it in French. In V-Tach, we already know what it looks like. It looks something like this. Tends to be pretty regular and wide complex. Now let's talk about this aberrancy. What aberrancy means is that you have aberrant conduction through these bundles here. So you have a bundle branch block. And what a bundle branch block does is it makes your QRS wide. So you might have a wide QRS, just normally because of a bundle branch block. However, now if you have a tachycardia plus a bundle branch block, it might look like this, right? It almost looks like V-Tach. It's hard to tell the difference. So SVT with aberrancy means you have a tachycardia, such as a supraventricular tachycardia, except you have an underlying aberrant rhythm like a bundle branch block. And it becomes difficult to tell the difference here. You might tell the difference is if you had an old EKG which showed the bundle branch block previously. Okay, so what is a pre-excited tachycardia? So normally we knew that the electrical impulse would come through here, through the AV node, and then through here. But what a pre-excited tachycardia means that there's an alternate way for electrical activity to get in here, and it could pre-excite the ventricles. And so what is our most commonly known one of these? Well, that's Wolff-Parkinson-White. So you'll see that delta wave in front of the QRS. That looks like that. Now if you have a tachycardia along with this wide QRS because of the delta wave, it's going to look again like, and it becomes hard to distinguish again. A ventricular paced rhythm is going to be a rhythm that starts somewhere in the ventricle. And torsade de pointes. Now let me just say one thing about these pre-excited tachycardias. The common example given is if you have someone who is in Afib, so they would have normally an irregular rhythm, and then if you throw in that delta wave, you're going to basically get a wide complex tachycardia that is irregular. So that's Afib plus the delta wave is a pre-excited Afib with RVR. Now why is this important? It's important for one main reason. If you give an AV nodal blocker to somebody who has this accessory pathway here, what you've essentially done is shut this path off. And this path has a natural tendency to slow conduction down. So if you do not provide another way down, this is the only one that's open. And now you're going to have heart rates, and now all the electrical activity has to go through here. And you can get heart rates reaching 300 beats per minute, which is pretty much not compatible with any good blood flow, and so really not compatible with life. So anybody who has a WPW delta wave, we don't want to give nodal blockers to, otherwise they're going to have this horrible tachycardia that's going to be almost impossible to stop, and they're going to die. So delta wave, no AV nodal blockers. So what can we give if we can't give an AV nodal blocker? Well, that's when we're going to give those other things like procainamide, amiodarone, and sotalol. And now you see why giving adenosine might be a problem, right? Because adenosine is an AV nodal blocker, and it might open this up to that super fast tachycardia. But the reason why they say it might be okay is because it is so short-acting that you could give it, it'll block this for a second, you'll see it speed up, and as soon as it wears off, you're going to see it go slow back down. And if that happens, realize, okay, probably shouldn't have done that. Let's not give an AV nodal blockers. Let's give one of these 3 drugs here. Finally, even though we've already covered them a little bit. Let's look at these irregular tachycardias. So if it's irregular and narrow, it's probably either Afib with RVR, rapid ventricular rate, or it might be that multifocal atrial tachycardia. It could be a sinus tachycardia with frequent premature atrial contractions as well. The way to really know is to get an EKG and take a look. If there are weird looking P waves that keep changing, it's probably this. If there are P waves most of the time and every now and then there's a beat that has something that looks different, it's probably this. If there's no P waves at all or a wavy bass, it's probably Afib with RVR. And so treatment of Afib with RVR is twofold. You want to control the rate and control the rhythm. Since most of that electrical activity is going through the AV node, you can give an AV nodal blocker. And so we know that's adenosine, which won't work very long, calcium channel blockers, and beta blockers. And ultimately, you'd like them not to be in Afib anymore, so you'd like to push them back into sinus rhythm. However, the problem is, if they're in Afib, there's always a chance that they have a clot that's formed in their atria, especially if it's been more than 48 hours. Many times you will not know. Some patients will know. They'll say, yeah, I could tell when this thing started, and it started half an hour ago. Those patients, it might be safe to convert their rhythm. But if you can't tell, or you have no idea if it's been 48 hours or longer, then don't do it. Admit them, let them get a TEE, let them get heparin if necessary, and let them be converted once you are sure there is no clot in the atrium. So if it's irregular and wide, then the thing you have to worry about really is that thing we just talked about, which is atrial fib with pre-excitation, with the thought that you're having AFib, but you have this accessory pathway going down. And we know that if we block the AV node in someone who has one of these accessory pathways, we're going to get this super fast tachycardia that is not compatible with life. And it doesn't have to be just WPW, but that's the main one we know. There's also something called the James bundle or the Lowen-Ganong-Levine. So the treatment here is no AV nodal blockers, but maybe procainamide. And finally, if it's polymorphic and irregular, think torsade. And torsade is usually caused by one of two things. It's either from a prolonged QT, and that's what it is most of the time, and if it's not that, then it's going to be ischemia. If it's from a prolonged QT, then magnesium will probably be the drug of choice for you. And of course, if they're unstable, you would shock them. If it's not due to a prolonged QT, maybe you have an old EKG that showed a normal QT, then it's probably ischemia, and your drugs would be amiodarone or a beta blocker, and you got to fix that ischemia, so they need to go to the cath lab. In this case, IV magnesium will not help. It probably wouldn't hurt, so if I saw torsade, I'd probably give IV magnesium, and if that didn't work, I'd start considering some of this other stuff, especially if I had an old EKG showing no previous prolonged QT. So that's it. Let's take a quick look back here. At why we did things now. So when we look back at the rhythm, we know that we have a tachycardia, and we're calling that anything that is above 150, because anything less than 150 is probably due to some other causes. If they're unstable, meaning they have any of these symptoms, we're just going to shock them, and we're going to shock them by using synchronized cardioversion, which means we want to shock them on the R wave, not on the T waves, because the R on T causes some badness to happen. And so there's the doses you want to use, depending on what rhythms you think you have. If you can, give them something to sedate them, because that's going to hurt. If they are not unstable, go ahead and get an EKG and decide if they're narrow or wide. If it's narrow complex, it's most likely going to be going through the AV node, and so you can give some AV nodal blockers, such as a vagal maneuver, adenosine, beta blockers, or calcium channel blockers. A wide complex is probably not going through the AV node, and so you might want to give one of these drugs, which will not close off. that AV node, thereby leaving any accessory path open. Now we looked and we know that there are some wide complex rhythms that probably do go through the AV node, namely that SVT with aberrancy, that is SVT with an underlying bundle branch block that was there already. But if you can't tell, it's always best to assume the worst. Assume that it's the wide complex. And here are our doses for those drugs we were going to give. And we talked about the tachycardias already. We talked about sinus tach, reentrant tachs, autonomic tachycardias, wide complex, and irregular ones. And that's it for the tachycardias. Thanks for listening. Bye.